noticed sometimes in shops is written cash today and credit tomorrow, so that when you go the next day, it will still read as cash today and credit tomorrow. So yes, tomorrow never comes. If you waste your today thinking about what tomorrow will be, you are wasting your today. Today is the only thing that you have in your hand. This moment is the only thing that you have in your hands. If you want to make your tomorrow beautiful, make your today oriented to your goal, how you want your tomorrow to be. And you do not have to worry about the future. Your tomorrow will automatically be how you want it to be. So yes, the future depends on what you do today. So use your today well. This moment is the golden moment. This is the only thing that you have. So with that, we start with another very important topic of the year, and that is chronic squamous otitis media. Now, we already know that chronic otitis media, the name itself tells you it is otitis media, which is chronic, which means that the middle ear is chronically getting exposed to infection from outside. Now, we already saw that for this to happen, for the middle ear to get exposed to infection chronically from outside, there has to be a permanent abnormality of the tympanic membrane. Yes, so characteristic of chronic otitis media, we already know is a permanent abnormality of the tympanic membrane. And this chronic otitis media can be of two types. It can be either chronic mucosal or it can be chronic squamous. We already have seen in the previous module what chronic mucosal otitis media is. Just a quick recap. Yes, whenever the permanent abnormality of the tympanic membrane is a permanent central perforation, this will chronically expose the middle ear mucosa to infection from the outside, and this is what is chronic mucosal otitis media. Yes, so because of repeated infection, patient will have discharge, patient will have deafness, and what do? Repair this permanent abnormality. The cause is the permanent abnormality, repair it. Yes, so how do you repair it? By a myringoplasty. If the ossicular chain is also gone, then maybe a tympanoplasty. We already saw that. Okay. Now, what is this permanent abnormality of the tympanic membrane which leads to chronic squamous otitis media? So, in this module, we are going to do chronic squamous otitis media. Chronic squamous otitis media is also known as unsafe CSOM, or it is also known as atticoantral chronic otitis media, but most appropriately and most commonly nowadays it is known as chronic squamous otitis media, because this name tells you everything about what it is. It is a otitis media which is because of presence of squamous epithelium in the middle ear, and this presence of squamous epithelium, stratified squamous keratinizing epithelium in the middle ear is what is known as cholesteatoma. So what is chronic squamous otitis media? It is the presence of stratified squamous keratinizing epithelium in the middle ear. And this is what is known as cholesteatoma. This is what is known as cholesteatoma, right? So what we know is that the middle ear does not have stratified squamous epithelium. What do we have in the middle ear? The mucosal lining is the ciliated columnar, or it is the columnar epithelium. So if the stratified squamous epithelium is going into the middle ear, the first thing that we need to know here is how will it go into the middle ear? From where will it go into the middle ear? And the second thing is, if at all it goes into the middle ear, what will it do in the middle ear? What destruction? How will it cause the destruction that will lead to otitis media? So yes, the first thing is that if the stratified squamous keratinized epithelium goes into the middle ear, how can it go? So it can be present either congenitally. That is what is known as congenital cholesteatoma. So if this epithelium is present because of congenital cell rests which were present in the middle ear, which were supposed to develop into mucosal epithelium, but because of some abnormality, they develop into stratified squamous epithelium. That is what is congenital cholesteatoma. So congenital is which is present congenitally. Yes, it is present congenitally. And if it develops later on, that is what is known as acquired. So acquired means the stratified squamous epithelium is going later on into the middle ear. So can you tell me, if there is stratified squamous epithelium which is going from outside into the middle ear, from where will it go? In the whole of the temporal bone, in whole of the ear, only one area of the ear is lined by stratified squamous keratinized epithelium. What is that area? Yes, that is the external auditory canal, which means if it goes into the middle ear later on, then it is going from where? Yes, that will go from the external auditory canal, yes, through a permanent abnormality of the tympanic membrane. So when it goes later on from the external auditory canal, that is what is known as acquired cholesteatoma. So acquired means it is going later on from the external auditory. It is going from external auditory canal into the middle ear. And this acquired can be divided into, it can be either primary or it can be secondary. So before we go to what is primary and what is secondary, I want you to first identify this. What is that you are seeing here? Yes, we are seeing keratin accumulated in the external auditory canal. Will we call this as cholesteatoma? Yes or no? This is keratin accumulated in the external auditory canal, so that is nothing that is not supposed to be here. In the external auditory canal, the normal lining epithelium is the stratified squamous epithelium. So if the keratin accumulates in the external auditory canal, we will not call this as cholesteatoma. We will call this as keratosis obturans. This is keratosis obturans. Keratosis obturans. If by chance there is a fracture of the temporal bone, fracture of the external auditory canal, and there is a cut in the bony part of the external auditory canal, and then the epithelium from the external auditory canal migrates inside this cut. So it is not supposed to be there. And there keratin accumulates, that can be known as external auditory canal cholesteatoma. Is that clear? So what we need to know is that what is cholesteatoma? Quickly, can you tell me? It is stratified squamous epithelium anywhere in the middle ear, in the mastoid, anywhere in the temporal bone where it is not supposed to be. So if it is present in the external auditory canal where normally stratified squamous epithelium is present, we will not call it as cholesteatoma. Is that clear? So middle ear, mastoid, anywhere in the temporal bone where it is not supposed to be, where it is not normally present, where it is not normally present. Okay, so now we have seen that what is cholesteatoma, and this cholesteatoma is what is the chronic squamous otitis media. Now let us see what permanent abnormality of the tympanic membrane will make this epithelium to go from the external auditory canal into the middle ear. So if this epithelium from the external auditory canal goes into the middle ear secondary to a perforation of the tympanic membrane, this is what is known as secondary cholesteatoma. Is that clear? So secondary is, it is going into the middle ear secondary to perforation. Secondary to perforation of tympanic membrane. Okay, now we will make it more clear now. Okay, so now if it is secondary to perforation, can you tell me any condition where there is a perforation of the tympanic membrane? Yes, we just saw in a safe Csom, following acute otitis media there can be perforation, following trauma there can be perforation. So can the epithelium from here migrate into the middle ear? It does not happen. Why? Because here we have the stratified squamous epithelium lining on the outside of the tympanic membrane, and just inside we have the mucosal epithelial lining on the inside. So when this epithelium will grow, it will meet the endothelial lining on the inside. When the epithelium will grow from here, it will meet the endothelial lining that is just present very near to it. There will be contact inhibition, and this stratified squamous epithelium will be prevented from growing into the middle ear. Then what perforation is that on the tympanic membrane which will allow this epithelium to go into the middle ear? Yes, for that to happen, the perforation has to be marginal. So we will make this, what we have written, more accurate. Secondary to what perforation? Secondary to a marginal perforation of the tympanic membrane. So now let us see what a marginal perforation is. Yes, marginal perforation, we've already seen. Marginal perforation means that the annulus is eroded. Yes, marginal means that the annulus is eroded. Annulus is eroded. Now please understand, annulus is eroded means what? It does not making sense, no? See, annulus is eroded is another way of telling that the whole of the tympanic membrane over the bone over the bone is missing. The bone in that area where the tympanic membrane is attached at the margin is now exposed completely. If the annulus is absent means specifically only the annulus is absent. It is not that. It means that the bone in that area of the margin has got exposed. So completely the epithelium, even the epithelium, the endothelium, everything in that area of the margin has got eroded. And can you tell me that a marginal perforation results following which condition of the year? Yes, a marginal perforation results following marginal perforation. It results following, do you remember? Yes, ANOM, acute necrotizing otitis media. So now whenever there is a perforation like this, where all in the margin the bone is completely exposed, so now the epithelium here is eroded, endothelium also of some area is eroded. So now the epithelium here will get a chance to migrate into the middle ear. It will migrate into the middle ear till the endothelium is absent, and where it meets the endothelium, there the further growth will stop. Okay, so now the epithelium has been able to reach into the middle ear. Now in the middle ear, when it is present, it is bound to produce keratin. It is keratinizing epithelium, so it will produce keratin, and keratin is not supposed to be in the middle ear. So what will happen? Macrophages will be recruited to come and eat up all this keratin and all this abnormal epithelium. So now when the macrophages come to eat it up, they get transformed to osteoclast. Yes, and along with eating up the keratin, they also cause bony erosion. They release, the osteoclast release collagenases, acid phosphatases, these enzymes, which causes further erosion at the margins of the till where the epithelium is present. So now they are eating up the epithelium. Along with that, they are also eating up more endothelium also, which is the lining of the middle ear, normal lining of the middle ear. They are eating up that also. So now what happens? That we are getting another more area where the endothelium is absent. So the epithelium will grow further. Yes, so slowly, it will go on growing further, more and more erosion, and slowly over the years, it will grow from the middle ear, it will go into the mastoid, it will grow into the inner ear, it can go through the tegment tympani, it can go intracranially, it can go to the mastoid, from mastoid it can go again intracranially, it can go posteriorly to the sigmoid sinus. So over a very long time, all this erosion will occur and patient will present with complications. So yes, that is why this was known as unsafe CSOM earlier. Why? Because this used to lead to complications very, very commonly. Complications can occur following acute otitis media also. Complications can occur following the chronic otitis media mucosal also. But it is very common here, much more common here. Why? Because the erosion is actively occurring. And because it was leading to multiple complications, it was known as very commonly as unsafe otitis media. So because the complications can occur in others also, but it is much more common here, it was known as unsafe. Now, this theory of migration of the epithelium from the external aortic canal into the middle ear is what is known as, yes, it is asked in your exam, this is known as Haberman theory of migration. Haberman theory of migration. How you can remember this is that migration is occurring from one harbor to the other. From one harbor, that is the external aortic canal, to the other harbor, that is the middle ear. So that is, it is going from one harbor to the other. This is the Haberman theory of migration. And because this migration of the stratified squamous epithelium was gradually leading to erosion and multiple complications, this was also known as unsafe otitis media. And this theory of migration of stratified squamous epithelium from the external aortic canal into the middle ear is what is known as Haberman theory. And yes, this is asked in your exam, Haberman theory of migration. So this is the cause of secondary cholesteatoma. And the most common site through which the perforation, most common site of marginal perforation through which migration occurs is the posterior-superior marginal. As you can see here also, this is the posterior part, this is the anterior part. So it is posterior-superior marginal, posterior-superior marginal. How you can remember Haberman? I remember it as it is going, the epithelium is going from one harbor to the other. So that is how you can remember one harbor to the other. It is going from the external aortic canal harbor to the harbor of the middle ear. So it is Haberman theory. So when it goes into the middle ear, here what we are seeing is the granulation, that there is erosion of the area of the margins, the bone is getting exposed, and later on when the keratin deposits, and then that gives the appearance like this, as you can see here, seeing here inside the middle ear, all this white keratin is getting deposited. Yes, and slowly it causes erosion, it goes on growing, so it happens over a period of years. So what we know as of now is that what is cholesteatoma? Quickly tell me. Yes, what is cholesteatoma? Before that, yes, tell me what is chronic squamous otitis media? Squamous otitis media is presence of stratified squamous keratinizing epithelium in the temporal bone where it is not supposed to be. So where is it normally supposed to be? External aortic canal. If it is present in the external aortic canal, what do we call it as? Keratosis obturans. If the same keratin, if the same stratified squamous epithelium keratinized, it goes into the middle ear, into the mastoid, everywhere where it is not supposed to be, that is what we call as squamous otitis media. And this is what is this keratinizing epithelium present abnormal place is what is known as cholesteatoma. So quickly tell me, how can it be present? How can it go into the middle ear? Yes, how does it go into the middle ear? Yes, it goes, either it is present congenitally or it goes from the external aortic canal through a permanent abnormality of the tympanic membrane. So that permanent abnormality can be either a marginal perforation following ANOM. Yes or no? Yes. So then that is what is known as secondary cholesteatoma, secondary to marginal perforation. Now what is primary? Primary cholesteatoma means that the stratified squamous epithelium is going from the external aortic canal. Yes, it is going into the middle ear. Yes, but not secondary to a perforation. So how, if no perforation, how can it go through the tympanic membrane to the middle ear? Yes, it can occur through a retraction pocket. So primary cholesteatoma occurs, the root is retraction pocket. The root most commonly is retraction pocket. Retraction pocket. So quickly tell me, what is the meaning of retraction pocket? Retraction pocket means that the tympanic membrane has got retracted and this retraction has become permanent. If I ask you which is the most common site of tympanic membrane to get retracted, pars tensa or pars flaccida? Yes, the pars flaccida. Yes, and a pars flaccida or a pars tensa retraction, if at all it occurs, why is it occurring? What is the cause of all retractions of the tympanic membrane? Yes, it is eustachian tube obstruction. So what happens when the eustachian tube gets obstructed? There is negative pressure in the middle ear. If it chronically gets obstructed, the tympanic membrane gets retracted. And the more flaccid is the pars flaccida. So most commonly the retraction pockets are seen in the pars flaccida. Yes, so now have a look at this. So here we have the pars flaccida. This is the pars flaccida. And if the eustachian tube will get obstructed, what will happen? There will be negative pressure. Later on, fluid will collect. What is that condition known as? Yes, that is what is known as serous otitis media. Otitis media with effusion, which means that a retraction pocket will follow serous otitis media, eustachian tube obstruction, eustachian tube obstruction. That will lead to serous otitis media. That will lead to tympanic membrane retraction. Now, what will this lead to? What will this tympanic membrane retraction lead to? So see here that the retraction, when we know occurs, it occurs most commonly in the pars flaccida. So this will occur, it will go inside. In which space? Yes, what is this space? This space is the Prusak space. Prusak space of the epitympanum. Right? So now what will happen if the eustachian tube remains chronically obstructed? This will grow medially and this will get adhered to the malleus neck. We know that is the stage 2. Can you tell me what is this retraction grading? It was by whom? It is known as what grading? Yes, I asked you to remember as the pars tensa and the pars flaccida. Yes, the pars flaccida is top, so that is TOS classification. Pars tensa is lower down, that is very sad, it is SADE classification, right? So this is according to the TOS classification. It will get adhered to the incus. Now later on, what will happen when the eustachian tube remains further obstructed? Now this retraction pocket will grow further. Yes, so now a part of the retraction will hide behind the scutum. So what will happen? This will not be able to clear itself to the external auditory canal normally, which normally will happen. Normally the external auditory canal, the tympanic membrane outer layer is the same as the external auditory canal epithelium. So the epithelium from the outer layer of the tympanic membrane, normally it migrates out through the external auditory canal, goes out. Now here we have a part of the tympanic membrane which has got hidden because of the retraction pocket. So in this area the keratin will accumulate. So when the keratin will accumulate, macrophages will be recruited to remove this because it is causing chronic inflammation. It is becoming a keratin accumulation in a closed, more or less a closed area, which is not connected to the outside. That will lead to chronic inflammation. That will lead to macrophages coming there to eat it up, to remove it. They will get converted to osteoclast. And now what they will do? They will release enzymes, collagenases, acid phosphatases, and they, along with removing the keratin, eating up the keratin, they will also erode the bone here. They will also erode the bone here. So what will happen now? Now the sac will open inside, and again gradually it will start growing. It will grow. The macrophages will eat up, along with the keratin, they will eat up some normal mucosal epithelium also. So this keratinized epithelium will get more space to grow inside. Slowly over a period of years, it will cause erosion. It will grow inside. It will grow everywhere to the inner ear. It can go to the temporal lobe. It can go into the mastoid. Through the mastoid, it can go everywhere outside, leading to multiple complications. So this is how, what we just saw is that the keratinized epithelium is eroding. It causes damage. How it reaches from the external ear into the middle ear? Yes, through two roots. When it is acquired from the external auditory canal, it goes through a permanent abnormality of the tympanic membrane. This permanent abnormality, when it is a marginal perforation, we call it a secondary. And when it is through retraction pocket, that is what is primary. Is that clear? And this theory of the stratified squamous epithelium going from the external auditory canal into the middle ear through a retraction pocket is what is known as Witt-Mack theory. So Witt-Mack. So what is Witt-Mack? How you can remember Witt-Mack is retract. Retract is Witt-Mack. And the retraction pocket cause, what is the cause? It is otitis media with effusion or serous otitis media. And the space where this retraction pocket goes into most commonly is the Prusak space. It is the Prusak space. So quickly, if I write this down, so cholesteatoma can be either primary or it can be secondary, right? Cholesteatoma can be either primary or secondary. Congenital we are not dealing, we are dealing the acquired cholesteatoma. Acquired cholesteatoma can be either primary or secondary. Primary is through retraction pocket, the cause of which is otitis media with effusion. That is it. That is what we did. And secondary is secondary to marginal perforation. And the marginal perforation occurs secondary to acute necrotizing otitis media. Is that clear? So now when we have a look at this tympanic membrane, can you make out that slowly there is a small retraction here? Now it has gone and it has got adhered to the neck of malleus. That is what is the grade 2 toss 2. Yes. So here what you are seeing is that there is the retraction has become more deeper, and also there is erosion of the scutum. Can you make out what is scutum? Yes, scutum is the lateral wall of the attic of the epitympanum above the pars flaccida. So probably in this case, a part of the parts of the retraction pocket is now hiding behind the scutum, from where it is also causing erosion. So a part we are not able to see, that is the part maybe where the keratin flakes is hiding, and that is causing to leading to all this erosion. And here you can see this is the grade 4, where yes, we can see that a lot of it might be hiding, and maybe we are not able to see the clear picture at all. Sometimes even what you're seeing on the outside is so minute, just see, and on the inside, see how such a big, maybe this was completely filling the middle ear also and the mastoid also. When there is big cholesteatoma which is causing erosion, then that is what we call as active disease. Active disease. And here where there is a retraction pocket which is cleared, you can see the pocket, that is a prerequisite for the next stage of this stage to happen. But as of now, there is no cholesteatoma here. This is what is known as inactive. Inactive, yes. So what we are seeing is that squamous otitis media can be either active when the cholesteatoma is actively eroding, active erosion is occurring, whereas because of cholesteatoma and inactive means that right now erosion is not occurring, but yes, it has the propensity to become active anytime. And because this can go through the adductus into the mastoid antrum, this is also known as atticoantral. So what we saw is that chronic squamous is also known as unsafe because it can lead to complications, and very commonly it can go into the epitympanum. We can see retraction is occurring, that is part of epitympanum only. So through the adductus which connects the epitympanum to the mastoid, it goes into the mastoid. So it is also known as atticoantral otitis media very, very commonly. The most common site of the retraction pocket of primary cholesteatoma is, yes, it is the Prusac space, yes. So most common site of primary cholesteatoma is the Prusac space. In other words, this is the most common site of retraction pocket. Yes, the second most common site where a retraction pocket can occur is posterior-superior. Again, posterior-superior area, this area. Can you see this is the malleus here? So this is the anterior part. This is the posterior part. So posterior superior area retraction is the second most common site where retraction pocket can occur, leading to primary cholesteatoma. Posterior superior area of tympanic membrane. And can you tell me what is this route known as? The route of retraction pocket leading to the stratified squamous epithelium going into the middle ear, that is retract. We remember it as Whitmack. Yes, we remembered it as Whitmack. Yes, there can be other routes also which are not very common. They have been postulated that if the tympanic membrane, what is primary? Primary is that the tympanic membrane does not have a perforation, does not have a marginal perforation. So it has been postulated that if there is repeated infection through the eustachian tube into the middle ear, then because of repeated infection, metaplasia can occur, and that can lead to the mucosal epithelium to get converted into stratified squamous keratinizing epithelium. That is very rare. That is just one postulation, and that is what is known as Sarday's theory. Sarday's theory of primary cholesteatoma. Sade, have we heard Sade somewhere else also? Yes, that was the Sade only gave the classification for pars tensa retraction. So this is also the same Sade theory for cholesteatoma. You can remember Sade is what? It is squamous metaplasia. Metaplasia occurs because of repeated infection through the eustachian tube. So as for Sade, this is squamous metaplasia. And another theory has been postulated for primary cholesteatoma. What is that? Is that when on the tympanic membrane there is repeated injury like as in somebody has the habit of repeatedly cleaning the ear with blood or some pain or anything because of any reason, or because of some external infection, there is repeated trauma to the epithelium of the external aortic canal. Trauma as in not leading to perforation, but trauma leading to micro fissures, micro damage. So now what happens is, because of repeated trauma, later on the epithelium, when it grows, the basal epithelium, the basal lamina of the tympanic membrane, when it grows to heal the damage that has occurred, it grows on the inside also. It grows on the inside. This is what is known as the Rudy's theory. Rudy's is basal cell hyperplasia. It is something like a exaggerated healing process is occurring. The epithelium, instead of just covering the area which has got damage, is now growing on the inside also, and that is leading to the epithelium from the external aortic canal. The stratified squamous keratina is going into the middle ear, leading to cholesteatoma. But these are not very common, but yes, you need to know the names of these. Why? Because they are asked sometimes as in your MCQs as choices. But the most common out of this is Whitmack. And secondary to marginal perforation, what is that theory known as? Yes, how did I ask you to remember it? That is going from one harbor to the other. That is what is Haberman theory. That is the Haberman theory. Yes, so keep your pen down. Yes, quickly tell me. If there is chronic squamous otitis media, what is the cause? What is the cause? Quickly, yes, presence of squamous epithelium where? In the middle ear. Yes, in anywhere of the temporal bone where it is not usually present. What does the squamous epithelium do? It causes bony erosion. Bony erosion because of acid phosphatases, because of enzymatic erosion, because of collagenases, because of acid phosphatases. How does it reach the middle ear? Yes, either it is present congenitally, or if it is acquired later on, how does it go into the middle ear? Yes, through a permanent abnormality of the tympanic membrane. If the permanent abnormality is a marginal, it is going secondary to marginal perforation. What is that known as? Secondary cholesteatoma. Then what is the root, most common root of primary cholesteatoma? Retraction pocket. Most common site of retraction pocket is pars flaccida or Prusac space or attic. So now we know that how this squamous epithelium is migrating into the middle ear. We know that. Yes or no? Yes, through what permanent abnormality of the tympanic membrane? Yes, we know that. What it is doing in the middle ear? We know that. Yes. So we now very clearly know what is acquired cholesteatoma. Now, how will we know that this is congenital cholesteatoma? If you are seeing congenital, what will the appearance that will make you feel that yes, this is congenital cholesteatoma? What is congenital? Congenital means that stratified squamous epithelium has grown later on from cell rests which were present in the middle ear, which were not supposed to grow into stratified squamous. They were supposed to become mucosal epithelium, but because of some abnormality, they became stratified squamous epithelium. So in that case, the epithelium has not migrated from the external aortic canal, which means that on the tympanic membrane, we will not find any abnormality. We will see the cholesteatoma in the middle ear as whitish mass, but tympanic membrane will appear normal. Yes, which means it will appear something like this. The tympanic membrane is appearing normal, and behind that you are seeing a whitish mass, which is probably cholesteatoma. Now, are you very sure that this, when you see appearance like this, that this cholesteatoma which has gone into the middle ear, maybe it has gone through a perforation or through abnormality, and now that perforation has healed. The perforation of the tympanic membrane do heal. We know that, yes. So the epithelium went into the middle ear and later on the perforation healed. Or maybe this is a patient where some surgery was done of the middle ear, and because of the surgery, stratified squamous epithelium from the external ear got implanted in the middle ear. So how do we know it is congenital and it has not been acquired later on, even when the tympanic membrane is intact? So that is why, to avoid all these confusion, Levinson's gave the criteria, which is known as Levinson's criteria for congenital cholesteatoma. Yes, what is the Levinson's criteria? We will just see. And before that, just notice here, when it was acquired cholesteatoma, the most common area was the posterior part. Did we see marginal perforation? That is secondary was through a posterior marginal perforation. And if it is a retraction pocket, that is either in the attic or in the posterior, whereas the congenital cholesteatoma, the most common site is anterior. That is the most common site. Now, what is the Levinson's criteria? Levinson's criteria states that you are seeing a white mass behind the intact tympanic membrane, which means that right now when you are seeing the tympanic membrane is absolutely intact. Yes, tympanic membrane is intact, and what you are seeing is a white mass behind that. Yes, and when you are seeing the tympanic membrane, you are going to have a look completely at the pars flaccida as well as the pars tensa. The pars flaccida is also good, pars tensa is also good. And this has not healed following any perforation or any surgery. For that, you will take the history. You will rule out any previous surgery. You will rule out any previous history of ear discharge. Yes, here discharge indicates that there has been a perforation or any history of perforation. Is that clear? So what this Levinson's criteria is that right now when you are seeing a normal tympanic membrane behind which you are seeing a white mass, most commonly in which quadrant? In the anterosuperior quadrant. And what you are seeing clearly is pars densa and pars flaccida is intact. There is no history of perforation. There is no history of surgery. Is that clear? So now what comes to the mind is children are so prone to acute otitis media. So if any child has developed acute otitis media, following which there has been no rupture, all acute otitis media do not rupture, no? So if there has been no rupture of the tympanic membrane, that history we have ruled out. So if there is any history of acute otitis media, and in this child, we are seeing a white mass behind the tympanic membrane. Should we label it as congenital or should we label it as acquired? Should we say that there is some history of acute otitis media in this child, which is obvious for any child to have? Then is it a acquired or a congenital? So if it is just acute otitis media which has not led to a perforation of the tympanic membrane, and in this child you are seeing that there is a mass, white mass behind the intact tympanic membrane, then we take it as congenital. So if there are recurrent bouts of acute otitis media also in a child but no history of perforation, and in this child because of some other complaint the child has come later on to us and we are seeing a white mass, then it can be called congenital as long as there is no history of perforation. Is that clear? So this is what is known as the Levinson's criteria. Levinson's criteria for congenital cholesteatoma. So can you tell me some differences between adult cholesteatoma, which is usually acquired, and a congenital cholesteatoma? Yes, that is the site. Site is very important. Most common site for congenital. For congenital will be anterosuperior quadrant. Whereas of acquired, which is seen in adults. In adults, this is most commonly in the posterior-superior quadrant. And also in children, the chances of ossicular erosion is much more following cholesteatoma than in adults. So we now know what is a congenital cholesteatoma. We now know what is a acquired cholesteatoma, and this cholesteatoma is what leads to chronic squamous otitis media. So quickly now you are going to tell me if it is acquired cholesteatoma, most common route of primary cholesteatoma is, it can be either primary or secondary. If it is primary, most common route is retraction pocket. Quickly tell me what is this theory known as retraction, Witt-Mack. Yes, that has been a repeated question of your exam. Witt-Mack theory is retraction. That leads to primary cholesteatoma, and the most common site of primary cholesteatoma is Prusac space. Prusac, or it is attic, or it is pars flaccida. Which means if you are seeing any retraction pocket in the pars flaccida, if you are seeing any granulation in the pars flaccida, if you are seeing any perforation in the pars flaccida, it is squamous otitis media primary. Is that clear? Any abnormality that you are seeing on the pars flaccida, you have to take it for granted this is a primary cholesteatoma. Whereas in the secondary cholesteatoma, the most common route is Haberman. Most common route is migration. It is migration. Migration through which perforation? Yes, through posterior-superior marginal perforation. Posterior-superior marginal perforation. And it can be either active or it can be inactive. Okay, so now we know all the pathology of what is occurring in chronic squamous otitis media. Now you are going to tell me that if there is a patient who has something like this happening on the tympanic membrane, how will this patient present? What will be the complaint that he will come to you with? He will not come to you with this tympanic membrane, right? This is what you are going to see. But what will be his complaint? Yes, will this lead to discharge? Yes, there will be discharge. But can you see why the discharge is occurring? Yes, the discharge here will occur because of bony erosion. So it will be very minute. It will not be like the profuse ear discharge because of all the middle ear mucosa involvement in mucosal otitis media. Here it will be very scant ear discharge which is occurring because of chronic infection of the keratin that has collected and because of bony erosion, because of osteitis. So it is going to be a very scant discharge, and because of bony erosion, this discharge is going to be very, very foul smell. It will be of a lot of foul smell. So yes, this patient will have discharge which will be, the quantity will be very scant. The smell will be very foul. And what do you think? Will it be painless or painful? Yes, this is a chronic low-grade infection occurring. So pain will not be there in any chronic otitis media. In fact, pain is not there. So it will be painless. There will be no pain. No pain. And why does the bone erosion occurs due to? Yes, has been a question in your exam where one of the choice was that the bone erosion occurs because of pressure of cholesteatoma. Is that leading to bone erosion? No, it is because of enzymatic activity. Enzymatic collagenases and acid phosphatases. Phosphatases which are released from the osteoclast. So you are sitting in the OPD. Here is a patient who has come to you with a complaint that there is very foul smelling discharge coming from the ear, and that is on and off he has. Mainly he feels that there is some irritation in the ear. When he puts cotton and he cleans, he can notice that there is discharge. The discharge is not actually flowing out of the ear, but what he notices is that it is very foul smell. Even maybe his family and friends are able to note the smell that is coming from the ear. That is brought the patient to you, that there is a very foul smelling discharge. And yes, do you think the patient will have any other complaint other than discharge? Yes, there will be deafness. This is causing erosion of the ossicular chain. So there will be a lot of hearing loss. So there will be discharge, and second, there will be hearing loss. And that will be the main complaint most of the time, because discharge is scanty. The discharge that is foul smelling, that can be sometimes very, very foul smelling that the others are noticing it. But many of the times it is just when patient cleans the ear, he notices that there is discharge, and it is very foul smell. Main complaint that the patient comes to you usually with is hearing loss. So here is a patient who has come to you with hearing loss. Here is a patient who has come to you with typical foul-smelling scanty ear discharge. When you examine his ear, what you see is a picture like this. You see is a picture like this, or you see is a picture like this. How are you going to manage this patient? What should we do? If we give any medicine, will the stratified squamous epithelium in the middle ear dissolve? No, it won't. What we have to do is we have to go and remove all the stratified squamous epithelium from the middle ear, all the cholesteatoma. We are going to remove from the middle ear or mastoid till wherever it has reached. We have to remove all that. Yes, so we have removed all that, and next we do not want it to recur. So we want to close that permanent abnormality that has occurred on the tympanic membrane which has led to all this. So what we are going to do is the management here is surgical management. Medical management has no role at all. So the management will be surgical exploration. And what is the surgery that we do here to remove all the cholesteatoma and then to repair the tympanic membrane? We will just see now. And what will be the aim of the surgery? Yes, we do not want the patient to land up into any complications. So the main aim will be to give the patient a safe ear. And along with that, what is the complaint that the patient has come to us with? Patient has come to us with the complaint of discharge and hearing loss. So our aim is to give the patient a dry, and also very, very important is to give the patient a hearing ear. And before we go for the surgery, we exactly want to find out two things. First, how extensive is the disease? Yes. And second, what is the status of the ossicles? Will we be able to preserve it, or will we have to replace it with the help of some processes so that we can keep some processes ready before the surgery so that we will use it? So how will we know how extensive the disease is? Yes, so we will investigate the patient. Before you are operating any patient of squamosal otitis media, you will have to always go to see whether how extensive the disease is. For that, you will have to go for a high resolution CT. When I say that it is CT, what do I write? Any CT of the ear is always a HRCT, high resolution CT of temporal bone. We already know the whole of the ear is present like a tunnel in the temporal bone. So when I write HRCT temporal bone, I am asking for what? HRCT, high resolution CT of the ear. Yes, so that will tell me exactly where all the disease has gone, whether it has eroded the fallopian canal, whether the tegment tympani is normal or not, whether all the walls of the middle ear are normal or not. So that will make me very careful if the lateral semicircular canal is eroded or not. So I will be very careful if I know all this before surgery. So yes, before surgery, I will like to go for a HRCT. I will like to examine the ear very nicely with a microscope, that is known as examination. Under microscope, to see the ossicular status, also to see the cholesteatoma or the middle ear structures. So under microscope, this is known as EUM, examination under microscope. And very, very important, I will like to see the hearing loss, how much hearing loss the patient has before surgery. That is by audiometry, pure tone audiometry. Yes, I want to document how much hearing loss is there before surgery so that later on I can see how much the improvement is following surgery, following the prosthesis. So I will get this investigations done. And now when I am very clear, now let us see what is the surgery that we are going to do for this patient. So coming to the surgeries of the mastoid, the surgeries of mastoid are divided into either a intact canal wall, or it can be canal wall down. Right? Now, canal wall down can again be divided into modified radical, which is known as MRM, modified radical mastoidectomy, or it can be radical mastoidectomy. Is that clear? Yes. So, are you with me till here? Till here, what we have seen is that the patient comes to you, you are sitting in the OPD, patient comes to you with a complaint of foul-smelling ear discharge, there is deafness, and you examine the ear. The moment you examine the ear, you see what you see on the tympanic membrane is maybe a retraction pocket on the tympanic membrane, or a marginal perforation through which you can see in the middle ear cholesteatoma flakes. You can see the retraction pocket in the Prusac space in which you can see all the whitish cholesteatoma flakes. Yes. So you just a look of the tympanic membrane tells you this is cholesteatoma. So you know this is a squamous otitis media, and we know squamous otitis media is because of cholesteatoma, because of stratified squamous epithelium in the middle ear. We will have to operate it. No role of medical management. So we will operate it. We can go either for intact canal wall or canal wall down surgeries. Are we till here? Are you with me till here? Yes, okay. So now what is the meaning of intact canal wall and what is the meaning of canal wall down surgery? Let us first understand the intact canal wall and the canal wall down surgeries through this model, and then when we see the live surgery, we will be able to understand it there then. So here this model I have shown it to you earlier also. Here we are having the pinna here which I have removed. Anterior to that is the external auditory canal. Posterior to that is the mastoid. And I told you that, remember, this is like two halls, anterior hall and posterior hall. The posterior hall, which is the mastoid, is one common hall from lateral to medial. It is a one big hall. Whereas anteriorly, the anterior hall is divided by a curtain into two rooms. The lateral room is known as the external auditory canal and the medial room is known as middle ear. Yes. Please note here that this common wall that is between these two halls is one common wall. Yes, because these are two rooms, laterally, this is the common wall between the external auditory canal and the mastoid. And when I go medially, the name of the room changes. It becomes the middle ear. So then there is a common wall between the middle ear and the mastoid. Is that clear? So both the external auditory canal and the middle ear have a common wall between them and the mastoid. So the common wall between the external auditory canal and the mastoid is the posterior wall of the external auditory canal. This is the right ear. This is the face here. Yes, and when we go medially, there is a common wall between the middle ear and the mastoid. That is the posterior wall of the mastoid. Is it very clear till here? Okay. Now in this patient has a squamosal otitis media where I have to remove the disease from the middle ear as well as the mastoid. So what I will do is, I will first drill the mastoid. I will remove the disease up till the mastoid antrum. Now, once I've removed the disease up till the mastoid antrum, if the disease there is not very extensive, it is minimal disease. Now, to remove the minimal disease from the middle ear, because the disease is not very extensive in the mastoid, I am considering that the disease in the middle ear also is not going to be very, very extensive. So now to remove the minimal disease of the middle ear, what I will do is, I will make an opening here. Here, when I reach the mastoid antrum, I will make an opening in between the common wall between the mastoid and the middle ear. In this area, in the deep area, we know that anterior to it is the middle ear. Anteriorly is the middle ear. So this is the common wall between the mastoid and the middle ear. So if I make an opening here in this common wall, I can go through this opening into the middle ear to remove the limited disease from the middle ear. So when I make just an opening on the posterior wall of the middle ear, yes, which area? Facial recess area that we have seen earlier also, and I will show it to you in some time. So that opening is what, when I make an opening in the facial recess area to remove the limited disease of the middle ear, I have not damaged the posterior canal wall. This wall is known as posterior canal wall. It is a posterior canal wall. Why it is named so? Because it is the posterior wall of the external auditory canal also. It is a posterior wall of the middle ear also. So when I have made just an opening there, I have not destroyed it completely. That is what is known as intact canal wall surgery. I have left it intact. I have just made an opening there. Why it is known as intact, you will know when I tell you what is canal wall down. Okay, so now when in intact canal wall, what I do is, I have removed the disease from here through the facial recess. I have removed the disease from the middle ear also. Along with that, I will also have to go from here. Here the tympanic membrane might be having a marginal perforation. Here the tympanic membrane might be having a retraction pocket, and there will be disease in the middle ear also, which I want to remove from here also. So I will go through here also. I will raise the tympanic membrane. I will remove all the disease of the middle ear. I will repair all the unhealthy tympanic membrane. So what I am doing is combined approach. I am going from here also. I am going from here also. So I am going from anteriorly through the tympanic membrane also. I am going from posteriorly through the facial recess also. So this intact canal wall is also known as combined approach tympanoplasty. Combined approach. Why? Because I'm approaching the middle ear through both the roots, anterior as well as posterior, and I'm doing repair of removing the disease, repair, tympanoplasty, repair of all the ossicles and everything that was unhealthy. Now suppose when I reached the mastoid antrum, I saw that the disease was very, very extensive. So now, considering that the disease in the middle ear is also going to be very extensive, I know that just making a small opening on the posterior wall will not suffice to remove the disease from the middle ear. So now, to remove the disease from the middle ear, what I have to do is, I will have to get a better access so that I can visualize the middle ear completely. So for that, what I will do is, I will remove this complete common wall. This complete common wall between the middle ear, between the external ear, the middle ear and the mastoid. This complete common wall I will remove so that this all becomes a one cavity, and I can access the middle ear and the mastoid very nicely without any chance of leaving behind any disease, so that there is no recurrence. Yes, which means, now just see here, what I have done is, I raised the tympanic membrane, I placed it on one side. All that was unhealthy on the tympanic membrane I have removed. I went through the mastoid. I saw that the disease was very extensive. So now what I did is, this complete common wall between the external auditory canal and the mastoid, between the middle ear and the mastoid, I have completely removed. Can you see? Can you see that common wall is no more there? Up till the descending part of the facial nerve. This is the facial nerve. The vertical part of the fallopian canal. I cannot go further deep because that will damage the facial nerve. I will leave that up till there. I will remove this common wall. This common wall I will remove up to the descending part of the facial nerve. So now can you see how beautifully I can see the whole of the middle ear? I told you middle ear cavity and the mastoid, all these are very minute. We do these surgeries microscopically and just leaving behind a little bit of cholesteatoma. What is cholesteatoma? Stratified squamous epithelium. Just leaving behind stratified squamous keratinized epithelium, little bit anywhere will make your surgery useless. So if it is extensive, then no compromise on surgery, and so that there can be chance of recurrence, there will be residual, all that we do not want. So what we do is to improve our approach, to improve our access, so that we can visualize and remove each and every part of the disease. We remove this common wall. This common wall between the mastoid and the external aortic canal, mastoid and the middle ear, up till the descending part of the facial nerve is completely removed. This is what is known as canal wall down surgery. Have you understood that? That is very simple. When you see it, you never forget. So that is what is canal wall down surgery. This part of the posterior canal wall, which was lateral to the facial, descending part of the facial nerve, this all is known as the facial ridge. So now just see, what have I done? I have raised the tympanic membrane, and whatever was unhealthy on the tympanic membrane, I have removed all that. All the healthy part I have placed on one side, so that later on I can place it back like that. Yes, to cover the middle ear cavity. And now what I did is, when I went to the mastoid, I saw that the disease in the mastoid was very, very extensive. So I understood that the disease in the middle ear is also going to be extensively extensive. It is going to be very extensive, and just making a small opening on the posterior wall to remove the disease from the middle ear will not suffice. So to remove the extensive disease from the middle ear, see what I have done. I have removed this complete common wall in between the external aortic canal and the mastoid, in between the middle ear and the mastoid. This complete common wall I have removed up till the descending part of the facial nerve. That red thing that you are seeing, the red wall that you are seeing coming down, that is the part where the vertical segment of the facial nerve is going down. I cannot go further medially. I cannot remove that part. That will give facial nerve palsy to the patient. So I have removed up till there the common wall between the external aortic canal and the mastoid, between the middle ear and the mastoid, so that my approach, my access to the middle ear becomes excellent, so that I don't miss even a flake of the stratified squamous epithelium. Just what is cholesteatoma? Cholesteatoma is presence of stratified squamous keratinizing epithelium. Just a pearly white thing. You might just leave it in the middle ear. That will lead to recurrence of the disease, and you're operating the patient, you're doing this surgery totally useless. So what you are doing is to improve your access, to improve your approach to the middle ear, to improve your removal of disease from the middle ear and mastoid completely. I have completely removed this wall. So now the middle ear and the mastoid has become a complete common cavity. Yes or no? Yes. And I can get a very good access to the middle ear, to the mastoid, and I can remove everywhere where the disease was. I can reconstruct the middle ear, and then I can place this back after I have reconstructed the middle ear. But yes, after surgery, just note here, after surgery, even if I reconstruct, if I put the tympanic membrane graft like this, the external aortic canal, which was only this much, this here is the external aortic canal area. Yes, because there was a common wall between the external aortic canal and the mastoid initially. This I have removed. Even if I put the graft, tympanic membrane graft, after reconstructing, after removing the disease from the middle ear and reconstructing the middle ear, the temporalis fascia graft or the tympanic membrane graft I have placed like this. So now the external aortic canal, which was initially only this much, it has become so wide. Can you see this? Yes, it will become a very big external aortic canal. So that is what is known as that a very big cavity, very big external aortic canal or very big middle ear and mastoid cavity. It is a common cavity now, which we get after canal wall down surgery. So have you got that? What I do in canal wall down is, when I go to the mastoid, I saw that the disease was very, very extensive. I removed the disease from the mastoid. Now to remove the disease, extensive disease from the middle ear, to improve my access, improve my approach, I have removed this complete common wall between the external ear and the mastoid, between the middle ear and mastoid, up till the descending part of facial nerve. Is that clear? That is canal wall down surgery. Now when I draw it for you and when you see it in surgery, you will understand it. So let us see what we are doing in intact canal wall. In intact canal wall mastoidectomy, what we are doing is we are going through the mastoid, we are removing the disease from the mastoid, and then we are going into the middle ear by making an opening in the facial recess area. Can you quickly tell me the boundaries of facial recess area? Yes, so here is the external aortic canal, this is the curtain, the tympanic membrane, medial to that will be the middle ear, and this is the mastoid. So I am going through the facial recess. Yes, what are the boundaries of the facial recess? Yes, very good. This is exactly what you are seeing here is the facial recess. So this is the vertical segment of the facial nerve that forms the medial boundary. We have the chorda tympani here. Yes, that is forming the lateral boundary, and superiorly is the incus. What process of incus is this? Yes, this is a short process of incus. All this we have done in great detail in anatomy. What we are doing now is that intact canal wall surgery mastoidectomy is through the facial recess. Whereas if I remove this complete wall, this complete common wall between the external aortic canal and the mastoid and the middle ear and the mastoid, that is what is canal wall down, which means that when I do canal wall down surgery, how will that appear like? So here we have the medial wall of the middle ear. Here we have the posterior wall of the middle ear. I am drawing here. This is the mastoid. Yes, so I have gone through the mastoid, remove the disease of the mastoid, and here I am seeing the vertical segment of the facial nerve coming down. So now what I have done is the disease here is very extensive that I have removed. Now to remove the extensive disease from the middle ear, what I do is I remove this complete, yes, can you see? This complete posterior wall between the external ear, external aortic canal, mastoid and middle ear mastoid I have removed up till the descending part of the facial nerve. This is the facial nerve vertical segment. This is what is known as canal wall down surgery. Canal wall down surgery. Now canal wall down surgery can be either radical mastoidectomy or it can be modified radical mastoidectomy. In both radical and modified radical, we lower the posterior canal wall. In both the radical and modified radical, the middle ear and mastoid is converted into a common cavity. Then what is the difference? The difference is when you enter into the middle ear. When you enter into the middle ear, as the name radical means you are being very radical in operating. So yes, what you do in radical is all the middle ear mucosa, all the ossicles except if the footplate is healthy, this you leave behind because you don't want to remove it and create a fistula there. So if the footplate is healthy, that you leave behind. Along with, other than that, all the mucosa of the middle ear, all the tympanic membrane remnants, all the ossicles, everything is removed in radical, and along with that the eustachian tube is closed. Very, very important, eustachian tube is closed. Yes, whereas in modified radical, yes, you accentuate all the mastoid air cells. That is, you remove disease from the mastoid air cells. Yes, you remove disease from the mastoid antrum. Yes, you remove the common wall between the middle ear and the mastoid. But the moment you come into the middle ear, everything that is healthy, the middle ear mucosa, the tympanic membrane that is healthy, the ossicles that are healthy, everything you leave behind. That is what is modified radical. Yes, and after you have removed all the disease, whatever is healthy you have left behind, you go for a reconstruction. That is what is modified radical mastoidectomy. So in modified radical mastoidectomy, is the posterior canal wall lowered? Yes, posterior canal wall is lowered. Yes, here also it is lowered. It is lowered in both. When I say posterior canal wall is lowered, what is the meaning? Yes, it means that this part of the posterior canal wall which was present, it has been removed. So it is known as it was lowered. Now again, please note here that this part of the posterior, here we have the posterior canal wall. So this part of the posterior canal wall lying lateral to the vertical segment of facial nerve. This area is what is known as the facial ridge. Whereas this part of the posterior canal wall which is bridging over the facial. This is what is known as facial bridge. This is known as facial bridge. You need not know what is bridge and ridge. All you need to know is that when sometimes in your question is given that in MRM facial bridge is broken, facial ridge is lowered, all that means you are doing a canal wall down mastoidectomy. Is that clear? So yes, it is facial ridge is lowered, facial bridge is broken. All that is done in both radical and modified radical. Ossicles in modified radical, all healthy is preserved. Healthy is preserved. Whereas here everything is removed. What is preserved is only the foot plate. Yes, only foot plate of stapes. Only foot plate of stapes is preserved. Rest everything is removed. What is the status of eustachian tube? In modified radical mastodectomy, eustachian tube is normal. It is left as normal. Here it is closed. Here the eustachian tube is closed. Yes, now you will tell me, why are you closing the eustachian tube? In radical, why are you closing the eustachian tube? We know that eustachian tube is paramount for the functioning of the middle ear. So why are we closing it? We always check that the eustachian tube should be functioning. We are closing it in which surgery is a question of your exam. Yes, we are closing it in radical mastodectomy. Tell me, think and tell me why. Yes, now in radical, what are you seeing? You are removing everything from the middle ear, and in radical, when you have removed everything, you are not doing any reconstruction also. Yes, so if you are not doing any reconstruction, why at all? When will you like to do a radical? The patient came to you with what complaint? Mainly with hearing loss. So you are telling the patient that, see, in your ear there is a lot of disease. It is going superiorly. It is going to the brain. It can go all around, and you will have a lot of complications. So now what I am doing is I am removing all the disease. I have given you a very nice, safe ear. Patient will tell you, doctor, I cannot hear. That is my main problem. Yes, will I hear after the surgery? That is my main concern. So in radical, you are removing everything and you are not operating or you are not reconstructing also. So why are you doing that? When are you doing that? Yes, so we will do all that only when reconstruction of the middle ear will not be of any use. Which means that in any patient of unsafe or squamosal otitis media where because of the disease, the inner ear is completely gone, inner ear is dead. So if the inner ear is not there, inner ear is not functional, what is the use of reconstructing the middle ear? Only in that case we will go for radical. Otherwise, in rest all the cases we go for modified radical. In all cases of squamosal otitis media, in all cases of unsafe CSOM, tell me what is the management? It is MRM. If the disease is extensive, that you decide on the table whether you will go for entire canal wall or for canal wall down, or maybe by seeing the CT you can decide earlier also. But in all cases of unsafe CSM with complication, if it is a complication, yes, you will go for radical or modified radical. Again, modified radical. So all cases of unsafe CSM with the disease is extensive, modified radical. All cases of unsafe CSM, that is squamosal otitis media with complication, don't think in complication we will go for radical. In complication also we will go for modified radical. Even if the patient has developed any complication, our aim is also to remove the disease, along with that give hearing to the patient. So always our management will be MRM, modified radical mastodectomy. When will you go for radical? Only when reconstructing of the middle ear will be of no benefit, because the inner ear is dead. So now when the inner ear is already dead, you're not reconstructing the middle ear. Why expose it to repeated infection through the eustachian tube? So why not close that connection? The middle ear is not of any use. Let it not be of any problem also. So then what you do is you close this connection of the eustachian tube so that repeatedly whenever the patient has pharyngitis, now the infection will not come into the middle ear, which is totally useless, no ossicles, nothing, but it will lead to problem, it will lead to discharge. So just remove that connection. So the eustachian tube, that is why it's closed in radical. Tympanoplasty, that is reconstruction, is done in modified radical. Here it will be done. Here it is not done. Not done. So what is the indication of modified radical? All unsafe CSOM, all squamous CSOM, squamous otitis media with or without complication. without complication. And radical you will do when the inner ear is dead. When the inner ear is dead. No need of reconstructing the middle ear. So have you understood now what are the surgeries of the mastoid? Yes, what do you mean by surgeries of mastoid? Surgeries of mastoid can be intact canal wall. Intact canal wall is also known as combined approach. Combined approach tympanoplasty. Why it is known as combined approach tympanoplasty? Because in this you are going through the mastoid and removing the disease of the mastoid, as well as through facial recess removing the disease of the middle ear. Along with that, you are also going through the external artery canal to repair the tympanic membrane and the ossicular chain and repair the whatever disease through the tympanic membrane you can remove. Is that clear? So that is why you are going anteriorly as well as through posteriorly. So it is known as combined approach tympanoplasty. So when you are anyway going through by raising the tympanic membrane through the external artery canal, why at all make a small opening in the facial recess area to remove the limited disease of the middle ear? Why not remove all the disease through by raising the tympanic membrane only? Yes? What is the hidden area of the middle ear? Hidden area lies medial to the bulge of the fallopian canal, vertical segment of the fallopian canal. That is the area that you will not be able to inspect by raising the tympanic membrane. That is hidden just medial to the pillar on the posterior wall. What pillar? The vertical segment of the facial nerve. If you raise the tympanic from here, you will be able to see the pillar, but medial to that, the hidden area, you will not be able to inspect. So to inspect that hidden area and to remove the disease from it, that is the most common site of residual cholesteatoma, of recurrent cholesteatoma. So to remove the disease from that, you will have to make a opening just lateral to this vertical segment, and this is what is known as this area just lateral to the vertical segment is what is the facial recess area. Is that clear? So this is the vertical segment of the facial nerve. Just medial to that, this is the sinus tympani. Yes, sinus tympani or hidden area or infrapyramidal recess. To remove disease from here, you will have to make a opening here that is lateral to the facial nerve. This is the facial recess area. Is that clear? So now that you know what is intact canal wall and canal wall down, will you be able to answer these questions for me? Yes, can you tell me for extensive disease, you will go for intact canal wall or for canal wall down? Now this I will not answer for you. You will have to answer for me. I hope you have understood all that. Yes. So yes, for extensive disease, we will go for canal wall down surgery. So recurrence or residual will be common in intact canal wall or canal wall down. Yes, in intact canal wall, because here you are approaching the middle ear through a limited small opening. So whenever there is extensive disease, we do not go for intact because there are chances of residual and recurrent disease. The big cavity problems will be in intact canal wall or canal wall down. In intact canal wall, the posterior canal wall, which was the common wall, you have not destroyed. You have just made a small opening. So the external artery canal is this much only, and the mastoid, this is this much only. The external artery canal and the mastoid is not one complete cavity. So cavity problems like lot of collection of debris or discharge. Why? Because this external artery canal has become such a big cavity. So now there will be a lot of there is a lot of area for the collection of debris and discharge to occur. So this is common in canal wall down surgery. Chorda tympani is sacrificed in intact canal wall or canal wall down. Did you notice when we did the canal wall down, what we did is this posterior canal wall, complete up till the descending part of the facial nerve we removed. Yes. So did we remove the chorda tympani also? Did we sacrifice it? Yes, in all canal wall down, be it radical or be it modified radical, the chorda tympani is sacrificed, and this is what you will have to tell the patient before surgery, that the taste of one half of the tongue, one side of the tongue will not be there following surgery. So yes, chorda tympani is sacrificed in canal wall down. Canal wall down, what is canal wall down? Two canal wall down, radical and modified radical mastoidectomy. And because such a big cavity has been created, this patient following surgery, if the hearing, whatever reconstruction you have done following MRM, but still if the reconstruction is not very good and the patient is not able to hear optimally, very nicely, hearing aid will not be possible if there is such a big cavity. If there is such a big cavity, this patient following surgery will not be able to use hearing aid. So it will be possible to wear hearing aid only when the external auditory canal is of the normal size. So that is an intact canal wall. So now we know that whenever we are doing intact canal wall, because the approach is limited, complication can be that we are leaving behind the disease. Yes, there can be residual or recurrent disease. Whereas when we are doing a canal wall down, we are not leaving any speck of disease, but the complication can be because of the big cavity. There can be cavity problems. There can be hearing aid we are not able to give to the patient following that because of the big cavity. The chorda tympani we are sacrificing. Yes, but if there is extensive disease, don't think that yes, we can go, let me go for a limited approach. Always what is more important is to give the patient a safe ear. That is the first priority aim of surgery. Second aim is to give the patient a dry and a hearing ear. Is that very clear? So nowadays what we do is, when we do canal wall down, to avoid the cavity problems and to avoid the problems of not being able to wear hearing aid, after we have operated, after we have done tympanoplasty, we reconstruct the posterior wall. As you are seeing here, this here is the external auditory canal. This is the external auditory canal, and here you are seeing the tympanic membrane there. This is the mastoid. So we had removed this complete canal wall to do the surgery, and following surgery, now what we have done is we have reconstructed it. So we have reconstructed the posterior canal wall. That we can do with the help of the bone, or we can do with the help of cartilage that we take out from the concha, or we can take out the bone from all around, and we can reconstruct the posterior canal wall and obliterate the mastoid cavity. With the help of bone or with the help of cartilage, we can just fill in there, or this muscle, all the muscle, we can make flap and we can put it in the mastoid so that it will get this support, and we will reconstruct the posterior wall of the external auditory canal so that the cavity problems, so that the patient not being able to wear hearing aid post surgery will not be there. Also, suppose we have not reconstructed the posterior canal wall and the mastoid middle ear, the external auditory canal is such a big cavity. In that case, the external auditory canal opening, see the meatus opening is only this much. Whereas inside this, the external auditory canal and the mastoid, all that is a big cavity like this. Yes. And this cavity is not able to, all the wax and everything that is collected, it will not be able for it to come out through the small opening. And if we also want to clean it, we are able to see from here how much inside we can go posteriorly. So to avoid all that problem, if the posterior canal wall is not being reconstructed, in that case, what is done is that the meatus, external acoustic meatus, is widened. This is what is known as a meatoplasty. The external auditory canal, the cartilaginous part, that is the external acoustic meatus is widened. So this is done following which surgery? This is done following MRM. This is done following canal wall down surgery. Canal wall down surgery. So now quickly keep your pens down, sit straight. Yes, okay, very good. So now quickly tell me, what is chronic squamous otitis media? Chronic squamous otitis media is? Yes, it is presence of stratified squamous epithelium where? In the middle ear. Okay, what can be the different types of chronic squamous otitis media? Congenital or acquired? Okay, what is the Levinson's criteria for? It is for congenital cholesteatoma. Acquired cholesteatoma, what are the two types of acquired cholesteatoma? Acquired means it is going from outside, from the external auditory canal. So what is the permanent abnormality in acquired cholesteatoma? Yes, first tell me secondary. In secondary, it is secondary to marginal perforation. Marginal perforation occurs secondary to A and no M. Okay, what is the most common root of primary cholesteatoma? Primary is retraction pocket. Most common site of retraction pocket is Prusac space, most common site of primary cholesteatoma is Prusac space or attic or pars flaccida or pars flaccida. So here is a patient who has come to you with decreased hearing with foul smelling discharge. Why is the foul smell? Why is there the foul smell? Yes, because of osteitis, because of bony erosion. Bony erosion is secondary too. Bony erosion is because of pressure. True, false? No, it is because of enzymatic erosion. Enzymatic erosion in which enzymes? Collagenases, because of acid phosphatases. Okay, so if there is this appearance of the tympanic membrane, either retraction pocket or a marginal perforation through which you can see cholesteatoma, the management of squamous otitis media will be medical or surgical. Always it will be surgical. What surgeries can you go for? Yes, if you are approaching the middle ear through the facial recess approach, what is that known as? Intact canal wall, also known as combined approach tympanoplasty. If you are lowering the posterior canal wall completely, what is that surgery known as? Canal wall down. Name 2 canal wall down surgeries. Radical or modified radical. Posterior canal wall is lowered in radical or modified radical. In both radical and modified radical. All the mastoid air cells are excentrated and removed, and disease is removed from the mastoid in radical or modified radical. In both. Canal wall is lowered in radical, modified radical. In both. All the ossicles are removed in radical or modified radical. In radical. Footplate of stapes is preserved in radical. All the healthy ossicles are preserved in modified radical. All the healthy tympanic membrane remnants are preserved in modified radical. Eustachian tube is closed in radical. Reconstruction is done in tympanoplasty is done in radical. Meatoplasty is done following which surgery? Following canal wall down surgery. What is the canal wall down? Radical or modified radical. A patient of squamosal otitis media, extensive disease, radical or modified radical? Yes. For all cases of unsafe CSOM with complication management is always modified radical. We always want to give the patient hearing unless and until, what is the only indication of radical? Dead ear. A patient of unsafe CSOM, patient of squamosal otitis media presents with facial nerve palsy. Management will be modified radical. Complication, it is modified radical. Don't think of radical. Radical only when there is inner ear is dead has been mentioned to you. Patient of just squamosal otitis media, management. Extensive disease, management. Modified radical. If extensive disease is not mentioned also, and you have to choose one, by chance you have to choose one, intact canal wall down. Always go for canal wall down. Always go for MRM as the management of squamosal or unsafe otitis media. Is that very clear? So now let us quickly see how the surgery is done. Before we see these steps in the live surgery, I'm quickly going to show you this. So yes, it is a microscopic surgery. This post-oral incision is given. Can you tell me the name of this incision? This post-oral is known as William Wild's incision. So now the pinna has been retracted forward. As you can see, pinna has been retracted forward, and the instrument that is used to do this is what is known as the self-retaining hemostatic mastoid retractor. This was a picture-based question of your exam recently. This is used in which surgery was asked. So yes, it is used in the mastoid surgeries, and this thing that with which you are drilling the mastoid. Where exactly do you start drilling? Quickly tell me. Yes, this is the McEwen's triangle. So you start drilling at the McEwen's triangle, all the bony and cartilaginous landmarks of which you already know. So when you start drilling, this instrument with which you drill is what is known as burrs. They are known as drilling burrs. Burrs can be either a cutting burr which has got very sharp edges or a diamond burr. Whenever we are close to important structures, like we are close to lateral semicircular canal, or when we are close to the facial nerve, we use a diamond burr which removes the bone very, very slowly. Whereas when we are just starting the surgery, we use a cutting burr. And yes, one thing, some student asked me, yes, and then repeatedly the same question was being asked by many other students. I do not know what was the impetus. So what they asked was which burr is being used. What size burr do you prefer to use, a bigger size or a smaller size? So you might think by seeing this that we use a small size burr so that we can operate. No, a bigger size burr is always used. A smaller size burr, this is appearing when in this picture you are seeing it to be so big, it is actually very minute. Already it is very minute, and if it is a small size, it becomes like a pointed edge like this. Yes. So then when you are drilling, a little slip of your hand, it can go into anywhere all around such important structures. It can directly go into it. Where it will go, you will not be able to control it. It will just go and pierce. It will pierce into the facial nerve, into the inner ear, into the semicircular canal. It can go into the dura superiorly. That is why biggest possible for that area is used. So now we can see that we have drilled all the mastoid. We have opened all the mastoid air cells. I will orient you here before we go forward. This here is the external auditory canal. There is the pinna has been retracted forward. This is the mastoid. This is superiorly and this is inferiorly the mastoid tip. This is inferior. So now just see here what we have done. This here is the posterior wall of the posterior wall, the common wall between the middle ear and the mastoid, posterior wall of the middle ear. So here we will make a opening. We have made an opening on this wall, and this area, just notice here, this is the anteriorly is the middle ear. So here somewhere will be the auditus, which is the natural opening between the middle ear and the mastoid, connection between the middle ear and mastoid, that you are seeing clearly here. This has been widened, this, and through that you can see the incus, the short process coming like this. And this area, the fossa inclutis of the posterior wall, you do not destroy. You do not want that following surgery. If the incus is present, it gets dislocated and the hearing, whatever is there, is gone. So this area, the fossa inclutis area, this we leave behind, and below that we make an opening in the facial recess area. And through this facial recess area, you are able to see this. What is this? This is the round window. So this is the same approach that you do to introduce electrodes of cochlear implant into the middle ear. This is how the endoscope looks like. And when you have made an opening here, you can easily through this area inspect this area, which lies medial to the vertical segment of facial nerve, which is known as the sinus tympani, or the hidden area of the middle ear. So this is what is otoendoscope. And now suppose in the mastoid, what you found that was the disease was very extensive. Just see here, this is the cholesteatoma flakes that you are seeing. So I hope you already oriented. This is the mastoid. This is the superior part. This is the inferior part. Here we have the external auditory canal, and when we go deeper will be the middle ear. Yes. So here we have cholesteatoma. All that cholesteatoma once we have removed, just see now here. Here we can see through, this is the posterior, this is the common wall. This is the common wall between the external auditory canal and deep, that is the middle ear. And we have removed all the disease from the mastoid. And this we are trying to remove through the auditus, the limited disease of the epitympanum. Now we are seeing that the disease is quite extensive in the middle ear. So now next what we are going to do is this complete wall between the external auditory canal, middle ear and the mastoid we are going to remove. That is what we saw. So yes, see, the removal of this common wall has started. And yes, we have removed this. What we are removing is the facial bridge and the facial ridge. So see, now we have removed, and up till the descending part of the fallopian canal we will remove, converting the mastoid and the middle ear into a common cavity. This will now be a big common cavity. So if this is of the other ear, this is the mastoid, this is superior, this is inferior, this is the common wall, this is the posterior canal wall, this what you are seeing is the middle ear here. Yes, so this is what is intact canal wall when you go by making an opening there into the middle ear. And just see here, this complete wall, common wall, has been removed. This is canal wall down, where you convert the mastoid and the middle ear into a common cavity. You drill down up till the descending part of the facial nerve. Now all this just telling you that would have been very simple, and just in a few words and a few lines would have summarized everything what we are doing. But yes, I know that this is something you do not understand. That is why I took the help of the model, and that is why I am showing you all these pictures, because once you understand, it will be a reflex. Just after understanding this all, what you need to know, just you need to know that canal wall is lowered in what? Yes, intact canal wall, where is the opening made? Residual is common in, recurrence is common in, mastoid and middle ear is converted into a common cavity in. Yes, so you just need to answer all these questions, but unless and until it is clear to you, ki chorda tympani is sacrificed in. So unless and until it is clear to you, now if any of this is asked from you, it will be just a reflex thing that you will quickly answer. But otherwise, you would be always ratifying, yes, this, making mnemonics and trying to ratify, and then ultimately, when you have answered also, you're not sure whether you have marked the correct answer or not. So I hope you have understood this. And when now you do the questions, you actually are understanding what you are reading, what you are answering. So now let us quickly have a look at the video of this surgery being done. Now this is a patient who has come with a complaint of hearing loss. He has hearing loss in his left ear, and discharge, he's telling that maybe sometimes if he puts the cotton he has discharge, but that is not a very profuse discharge which comes out. So still, let me have a look what it is. So now I have a look at his ear to see whether there is external ear or middle ear involvement, what it is. So what I saw was something like this. Yes, so that typically is appearing like a cholesteatoma. So can you tell me it is what otitis media? What should I write at the diagnosis? Yes, chronic squamous otitis media. What is this? Is it primary or secondary? Is it appearing primary or secondary? Yes, this is secondary. Primary, if it was primary, where would I see the cholesteatoma flakes or the retraction? Yes, that would be in the pars flaccida. So this is when I'm seeing something like this. This is a secondary, and what is the most common route of going of migration here? What is that known as? Yes, it is known as the Haberman theory. The most common theory is Haberman theory. The most common route is migration through marginal perforation. The most common type of marginal perforation, site of marginal perforation through which migration occurs is a posterior superior marginal. But here I can see it is almost a big perforation. And yes, the margins I can see are exposed here, all this. I cannot see any annulus. It is a dirty appearance of the posterior superior area that I am seeing. So now what should I do for this patient? Yes, do I need to do the tuning fork test and see anything, whether what more am I going to get from the tuning fork test? This shows that the patient is having hearing loss. The patient will be having a conductive hearing loss. What I want to know is how extensive the disease is. For that, I can get a HRCT done, and also or I can get a PTA done to see what the ossicular status is, how much is the hearing loss, and also I can examine his ears under the microscope. So I will do all this, and then I will post him for some surgery. What surgery? Or should I give him some medical management? Should I just give him some medicines and send him and see the response? No role of medical management here. It is because of squamous epithelium into the middle ear that all that will have to be removed. What surgery do I do here now? Yes, I will have to go for a canal wall down. This is so extensive. I can just make out that an intact canal wall will not suffice. I will have to go for a canal wall down, a modified radical mastoidectomy. Yes, and once I have removed all the disease by a modified radical mastoidectomy, a canal wall down, I will like to go for reconstruction of the ossicular chain. Yes or no? Yes, okay. Would I also like to reconstruct his posterior canal wall? Yes or no? If I reconstruct his posterior canal wall after doing a MRM, MRM is intact canal wall or canal wall down? It is canal wall down, which means I have lowered his posterior canal wall. So if I reconstruct this, what benefit will it give to the patient? Yes, if I have reconstructed his posterior canal wall following surgery, he will have a small external aortic canal, a normal external aortic canal, because of which the cavity problems will not be there. Because of which he will be, if the hearing loss has not benefited much by the tympanoplasty that has been done, reconstruction of the ossicular chain that has been done, so then a hearing aid could be used then. So this is how the patient will present. This was just a quick approach of when actually the patient comes, what all, how you summarize this, all that we have studied here in unsafe or in chronic squamous otitis media. Before we see the video of ear surgeries, a note of caution for all my students. Please don't expect that whatever you are seeing, you are going to see. The moment you see, it will be absolutely crystal clear to you, like how it became clear to you when we read about it. The surgeries of the ear are not simple to understand, not only for you, but even for the PGs. It is not until they have assisted so many surgeries and they have reached up till the second year after assisting so many surgeries that they can actually make out what is being done. So definitely, if you see it for the first time, don't expect that it is going to be absolutely now perfectly clear and you will understand in the first time that this is whatever you are seeing. But I have tried my best to give you a glimpse, just a glimpse of what the surgeries of the ear mean. You have already understood it very beautifully when we have done the theory part, when we have understood the concepts part. This is just to give you a glimpse of what exactly we are doing in the surgeries. How much you are understanding is sufficient. I have tried my best to give you a very magnified view so that the steps that you need to know, at least they are visible, and how much you are understanding after seeing this is perfectly okay. So we just read and we just saw very clearly how we do the surgery for chronic squamous otitis media. The surgeries of the mastoid we just saw can be intact canal wall or canal wall down. Now let us see the surgical steps. Let us see exactly how we do the surgery. So here again the incision is the post-oral incision. I will orient you here first. So this is the left ear that is being operated upon. The incision is the same, the post-oral William Wild's incision. That is the superior end and that is the inferior end. So we can see the William Wild's incision, the post-oral incision has been given, and this incision will be deepened up till the periosteum of the mastoid, exactly how we did in chronic mucosal otitis media when we were doing a myringoplasty. So now we can see we have exposed the mastoid antrum area, the McEwan's triangle area, and now we have started the drilling. Please note this is a very sharp burr that we are using here, and the biggest size burr according to that area is used always so that it does not slip from the hand and go anywhere inside and damage these structures which are very important. Also note a lot of irrigation. You can see the water falling there. So a lot of irrigation is done during this drilling process. That is done for two purposes. First, to remove all the bone dust so that it does not occlude our vision, and also to decrease the temperature. While the drilling is being done, a lot of heat is produced. So that is done to lower the heat, to protect the important structures like the facial nerve, the semicircular canals from getting damaged. Now here please see, this is the posterior part where we are drilling, that is the mastoid. So please note here, I will like to orient you here. This here is the mastoid behind where we are opening. You can see a small opening into the mastoid which has been made. And this is the common wall. Anterior to that is the external auditory canal. So this is the common wall between the mastoid posteriorly and the external auditory canal anteriorly. When we go through the external auditory canal, medially that is the middle ear, and from the mastoid, when we go further medially, we will enter into the mastoid antrum. That is the largest mastoid air cell. Yes, the mastoid antrum is completely being opened, and yes, just note here, I will orient you again. This is the mastoid antrum. Here we have the common wall between the mastoid and the external auditory canal, we can see anteriorly. Also just note that the tympanic membrane has been raised along with the external auditory canal skin, and we can also see the middle ear. Now up till here, when we just open all the mastoid air cells to remove disease from the mastoid, this is what is known as cortical mastoidectomy. Cortical mastoidectomy is done for acute mastoiditis, which is a complication of otitis media that you will read when you do the complications of otitis media. But since we are doing the surgeries here, I just want to show you that only up till here when we do to remove all the pus and the disease from the mastoid antrum. That's it. That is what is known as cortical mastoidectomy or simple mastoidectomy or Short's operation, just drilling the mastoid to open all the air cells to remove the pus from it. So now let us see if there is extensive cholesteatoma in the mastoid, how it appears and how then we go for removal of the cholesteatoma. So this is a patient of chronic squamous otitis media where we are doing the mastoid surgery. This is the right ear of the patient that is being operated upon. Let me orient to you first. that is the superior end, and this is the lower end, that is the inferior. This is the mastoid that we are seeing. It already has been drilled, and we are just about to open into the mastoid antrum to see whether there is cholesteatoma in it or not. And that is the anterior part where the pinna has been retracted forward. So now let us just see. Yes, we have opened the mastoid antrum. We have drilled into the mastoid antrum, and we can see, yes, we can see a lot of cholesteatoma flakes there. Please note the continuous irrigation is being done, and the biggest possible cutting drill is used when we start drilling initially. Yes, we can see that it was filled with cholesteatoma, which is being removed, which is being suctioned out. Note the sharp drill. And to drill the bone initially, sharp drill or cutting drill is used. When we are close to important structures like the facial nerve, lateral semicircular canal, we use a drill which is not very sharp. That is what is known as a diamond drill. So this cholesteatoma, which is the keratinized epithelium sac, which is filled with keratin, all that is being removed from the mastoid antrum. And we have to be very precise. We have to remove all the epithelium that we are seeing, all the cholesteatoma flakes, to prevent any recurrence. So we can see so much of cholesteatoma, so much of extensive disease this patient is having. Now all the disease from the mastoid has been completely removed. So once we have removed the disease completely from the mastoid, as you saw that we did that just now, now we will go through the connection between the mastoid and anteriorly the middle ear. So let me orient you. That is the mastoid here. And here this is the common wall between the mastoid and the external auditory canal. Deep when we go from the external auditory canal, when we go further medially, that is the middle ear. And you can see the suction tip that is come from the mastoid into the middle ear. Can you tell me through which connection it has come? Yes, that has come into the middle ear through the arditus. So we know that the disease goes from the middle ear through the arditus into the mastoid. Now when we are removing the disease, we are removing from the mastoid through the arditus, and then we are going into the middle ear. So we have removed the disease from the mastoid. Now we have cleared the arditus. Each and every speck of the disease needs to be removed to prevent any recurrence. Now we are into the middle ear, and yes, this was a very extensive disease, and we know that in extensive disease, to get a good approach to access the middle ear, we do not want this wall. This wall is hampering our access and our visualization of the middle ear cavity. So now what we are going to do is, we will remove this common wall, this wall between the external auditory canal and the middle ear. Anteriorly and posteriorly we have the mastoid. So this common wall we are going to remove. Remove it up till the descending part of the facial nerve, that is the vertical segment of the facial nerve. So you can see here, this is the common wall that is being drilled down. You can see the irrigation is continuing. And yes, what we are doing is, as we are lowering the canal wall, the access to the middle ear becomes very good. The visualization of the middle ear becomes very good, and we can remove each and every speck of cholesteatoma flake from the middle ear. So we will lower it down up till the descending part of the facial nerve. So yes, this is the diamond burr that we are using. You can see it is not sharp at all. And we always drill parallel to the facial nerve, so that it does not get injured. So please note that the mastoid and the middle ear has been converted into a common cavity here. So all the disease from the mastoid as well as the middle ear has been removed by lowering the canal wall. This is what is canal wall down surgery. The mastoid and middle ear is converted into a common cavity, and each and every speck of cholesteatoma has been removed. This is what is canal wall down. We lower the common wall between the mastoid and the external auditory canal, mastoid and the middle ear up till the descending part of the facial nerve. So once we have removed all the disease from the mastoid and the middle ear, if we leave behind everything that was healthy and we go for a reconstruction of the ossicular chain of the hearing apparatus, then that is what is known as modified radical mastoidectomy. Whereas if we do not reconstruct anything, we leave behind only the footplate of stapes. If it is healthy, rest everything we remove. Along with that, we close the eustachian tube. That is what is known as radical mastoidectomy. Now let us quickly see how an intact canal wall surgery looks like. Again, this is the right ear, so that is superior. that is inferior, that is anterior, that is the external auditory canal, and here this is posterior, this is the mastoid, this is the common wall between them. This is the posterior wall of the external auditory canal that we are seeing, and we have opened up till the mastoid antrum. The adductus has been exposed, it has been cleared, and please note here we can see the body of the incus and the short process of incus. We know that the short process of incus projects posteriorly towards the posterior wall of the middle ear. So it is very, very important to do this surgery under very good magnification and to identify the landmarks before you start making an opening anywhere, or before you start exploring and removing the disease or drilling further. So now we know that that fossa incutis area we will leave behind, and below that we will make an opening. That is the area of, yes, the facial recess area. The facial recess area. Medially, we have the facial nerve in the boundaries of the facial recess, the descending part or the vertical segment of the facial nerve we have down, that is medial. Here we have the chorda tympani going laterally, and we have superiorly the fossa incutis area where the short process of incus is projecting. We can see there. So this opening is when we made in the facial recess area. This is what is known as intact canal wall surgery, and through this opening we remove the limited disease of the middle ear. This is also the approach when we have to pass electrodes of cochlear implant from the mastoid into the middle ear, because through this approach you will be able to see, through this opening you will be able to see the round window very clearly, and then the electrodes can be passed through the round window into the inner ear. So I hope that now that you have seen how an intact canal wall and a canal wall down surgery is done, it is absolutely clear to you, and you will never forget it, and you will be able to answer all the questions related to this.